Okay, good afternoon. Welcome to Medicine Grand Rounds. We have two speakers today, Dr. Ali Musani and Dr. Jamie Studts, who are going to do a combined Grand Rounds on lung cancer screening challenges and emerging solutions. I'd like everyone to submit their questions during the presentation to the Q&A box, and we'll be monitoring that box during the presentation, and we'll get all of your questions answered during the Q&A period for the Medicine Grand Rounds. Let me introduce both speakers. Dr. Musani is a professor of medicine and surgery here at the University of Colorado. He's the director of the Advanced Bronchoscopy Program and the vice chair in the Department of Medicine for Global Health. Dr. Musani grew up in Pakistan. He received his BS and MB degree from Dow Medical College in Pakistan, and then did his house staff training at State University of New York in Brooklyn. Subsequent to that, he developed expertise in pulmonary medicine at Jefferson when completing his fellowship, and then embarked on a career in interventional pulmonary medicine by doing a second fellowship at the University of Pennsylvania and getting subspecialty training in France and also Japan. He has served on the faculty at the University of Pennsylvania, National Jewish. He served as a chief of pulmonary and critical care medicine at the Medical College of Wisconsin. And then we were fortunate to recruit him back here to head up the Advanced Bronchoscopy Program in 2018. Dr. Musani has focused his career on two very important aspects in medicine. One, innovative approaches to advanced airway management and diagnosis of lung cancer, and global health issues, both education as well as training. Dr. Jamie Studts is a professor of medicine here in the Division of Medical Oncology. He is also the scientific director of behavioral oncology within the division. He received his bachelor's degree from Loras College in psychology, and received his PhD in the Department of Clinical and Health Psychology at the University of Kentucky. He has served on the faculty at the University of Louisville, the University of Kentucky, and this past year we were fortunate to recruit him to the University of Colorado. His area of interest is lung cancer screening, risk assessment tools, and developing knowledge for providers as well as assistance in making decisions. So it'll be a very interesting talk. I want to encourage all of you to put your questions in the Q&A box, and we'll get to them during the discussion portion of Grand Rounds. Dr. Musani?
Thank you, David. And thank you for the nice introduction. This will be, as David mentioned, a sort of a joint talk. First half will be by me, and then I'll cover mostly the local and sort of a clinical aspects of lung cancer screening, workup of lung nodule, and risk stratification in patients. And then Jamie will give you a broader perspective of research behind all that and further implementation globally and nationally. So I'll try to finish in time to leave some time for Jamie. These are my disclosures. I'm mostly a researcher and consultant for these companies. So what we'll try to do is, in the next 25 minutes or so, discuss the background and evidence behind lung cancer screening. And then probably predominantly I'll discuss what is that goes in the workup of a pulmonary nodule when you see a patient in your clinic or refer patients to us at the nodule clinic. And then finally, what is the appropriate workup, and then finally referral patterns for these patients in terms of sending them for appropriate treatment, and then continue to follow up until the resolution. just to give you a sort of a broader sense of what we're dealing with here is, so that lung cancer is, although number 2 for men and women in terms of incidence, and it's not, the prostate is the number 1 cancer that afflicts men, and then breast is number 1 in women. But in terms of mortality, lung cancer kills more men and women than the second, third, and fourth cancer combined. So if you combine colorectal, breast, and prostate, they kill almost equal amount or slightly less than the amount of patients killed by lung cancer. So extremely high death rates from lung cancer. And if you want to individually look at that, the lung cancer kills more than 2.5 times men than the prostate cancer, and almost 1.5 times women than the breast cancer. So it sort of tells you how big of a problem we're dealing with. And the goal of the screening for lung cancer is to find the tumor in its earliest possible stage. And then the second goal is to then treat them before these cancers become advanced stage and increase the extremely complicated course and fatality rate due to high stage cancers. As you all know, that the breast cancers and prostate cancers has been screened for decades and decades, and lung cancer just started recently. And there's a lot of social, political, and socioeconomic reasons why lung cancer screening did not start as early as breast or prostate. But fortunately, we're there now. It's approved. So the goal is to find the cancers as early as possible. So as you know, in 2011, this landmark study, basically laying the groundwork for the lung cancer screening in the US, was published in New England Journal, which showed that the death rates caused by tumors in patients who were screened with low-dose CT scan were 20% less. Relative reduction was about 20% in patients who were screened with CT scans compared to people who were screened with chest X-ray. And there was an additional 6.7% reduction in the death by any cause or all-cause mortality, was a total of 26.7% in patients who underwent routine low-dose chest CT screening in a high-risk group patients. So this was pretty strong evidence for lung cancer screening. These results were better than breast or prostate screening. And we all again wondered, why didn't we start it 20, 30 years ago? There are some issues there, like with any other screening, that there are false positive results, and there are increased interventions and procedures in patients who are screened and found to have nodules, similar to other screening patients in other cancers. And the goal is to cut back on those and have strategies to reduce those unnecessary procedures. And you will see most of my remaining talk will be focused on that. Currently, as we stand there, we need 308 patients screened to save 1 life, which is, again, as I mentioned, is a strong evidence in support of aggressive screening in high-risk patient population. And as a result of this national lung screening trial published in 2011, the United States task force and the CMS approved the lung cancer screening, and Medicare and Medicaid started paying for it, followed by all the insurance companies. And they all have slightly different criterias. The original NLST trial enrolled patients from 55 to 74, ages 55 to 74, patients who had 30 pack years smoking history, who were either actively smoking or had quit within the last 15 years. So basically a very high risk group for lung cancer. And then they excluded patients who had active malignancy because that basically is not the goal for screening. USPSTF or task force increased the age for screening, hoping to continue to have a higher impact on a large group of patient population, and kept the same inclusion criteria. And then also sort of reinforce the exclusion criteria that if the patients have active disease or have short life expectancy, or they're not able to undergo a definitive therapeutic procedure such as surgery, then there is no reason to screen them. And this is a common one that we miss in our clinical practice, that we don't consider patients who are poor candidates for surgery should not be screened. CMS had the similar, but again, slightly higher age, and then similar exclusion and inclusion criteria. So bottom line is, it's approved by all the major stakeholders in the United States. So let's quickly go over a case, and this clinical scenario will basically guide us through the entire procedure, entire process of patients' workup, and then finally taking this patient to the management. So a 66-year-old woman with 50-pack years of smoking history who quit smoking 6 years ago, present to University of Colorado Lung Cancer Screening Clinic. The patient was recently diagnosed with emphysema. So age, smoking history, emphysema. She was started a bronchodilator. Her father had a lung cancer and a smoking history, and she underwent counseling and shared decision-making. So very high-risk patient from all the inclusion criteria that you just saw. And then we always do a shared decision-making in the lung cancer screening clinic, which is required by CMS, and counsel for smoking cessation or maintenance of smoking cessation. She had a CT scan done, which showed a 1.4 centimeter pulmonary nodule. And that's where the workup starts. The patient could be in your primary care clinic, and you could say, okay, we'll do a CT for some other reason, and then you find a pulmonary nodule. So once the CTs and X-rays are done, the really important decision-making is on whether this was a incidental or screened, and then calculate the risk of this patient for having a lung cancer. And that drives how you proceed in terms of tissue sampling, and then further genetic workup, and whether this patient needs to go to the tumor board for management issues or diagnostic dilemmas or not. So if you start doing risk calculation, let's say talk about this patient. The probability that this nodule that we just saw in this smoking person who is above 55, has family history of smoking, and smoked up until a year ago and has emphysema, what is the probability that this nodule is cancer? Less than 5, 30 to 60%, more than 65%, or we cannot calculate the probability. And I know you cannot answer online, but the answer is more than 65% chance that this is a malignant nodule. And that basically determines what would you do next, and what would be the sampling or resection or tumor board presentation. So patients who are high risk, above 65 or so, are usually surgical candidates unless they have any other comorbidities, such as severe pulmonary hypertension, for example. And that's a big group of people. In some studies, there are about 1/4 of all the patients who show up with early stage lung cancer as a result of screening or incidental findings. Then comes the most complicated area, which is the gray zone always in any screening, that they don't fit into a very high risk or low risk. So they are somewhere between 10, 15 to 50, 60% risk group. And what do we do with them? And then the last group is the very low risk group, where you see a very small nodule, which is either screened or incidental, and you need to just basically follow this closely. And sometimes it's so small or calcified that you say, okay, you don't have to do anything. These are some of the risk calculators, and there are many out there. Brock is the one that we use mostly for screen patients. The reason is screen patients have sort of a different set of issues in terms of incidental, and as opposed to incidental. You know, you could find an incidental nodule in a 35-year-old person who fell off the bicycle and had a chest X-ray, and you saw a nodule. So those are considered sort of a low risk. These patients are inherently high risk. That's why we screen them. So there are different calculators for them. You plug in their ages, their history of lung cancer in the family, emphysema, nodule size, nodule location, and then it will give you the probability of malignancy in that nodule, and that drives your workup. There are others. For example, this Herder is usually used for people who've already had a PET scan, because PET positivity increases the risk for malignancy extremely high. As I mentioned earlier, there are many models to calculate these risks, and we sort of combine all of them in different situations. So the VA model looks at different risk factors, and the odds ratio for a person who has current or past smoking history to have a malignant nodule is very high, one of the highest odds ratios for lung cancer risk. Similarly, in Mayo model, people who have extrathoracic cancer malignancy previously or a speculated morphology of the nodule, they are considered to be very high risk. So many predictive models that take into considerations age of the patient, the smoking status, extrathoracic malignancies, nodule characteristics such as diameter of the nodule, speculation, or shape and size, all of that, and location help determine whether this is a malignant or benign nodule. This was a very comprehensive study published in New England Journal about 6, 7 years ago, which looked at many risk factors for having a malignancy, and it was sort of unusual to see that although smoking rates were lower in women for a very long time, but recently they have gone up, that the risk of having malignant nodule in women was more than men. It was 1.82 odds ratio. And nodule counts were not as high, which was thought to be a risk factor if you have multiple nodules. So solitary nodules are dangerous. Nodules in women are dangerous. Nodules in the upper lobes have very high odds ratio. So all of those goes into calculation. We all know size is a huge factor in determining whether the lung nodule is malignant or benign. So nodules which are less than 0.5 centimeter are considered very low risk. And most of the guidelines suggest not to follow them periodically. Nodules, once they're above 6 millimeter, most of the guidelines suggest that we should follow them with the CT scan at least for 2 years in terms of solid nodules and up to 5 years in ground glass nodules. And nodules bigger than 2 centimeter are extremely high risk, and in the right patient, they should be considered malignant until proven otherwise. We look at the shapes of the nodules. So again, speculated nodules, which is here, which has these tiny edges. In a very exaggerated form, it can almost look like a corona radiata, different lines coming out of it. These are considered extremely high risk nodules, and the smooth borders are considered low risk nodules. So once we find a nodule, it could be benign or malignant. Even our CTs, high risk, or even PET scans, their specificities and sensitivities varies from what part of the country you're in. So if you did the same CT scan in Mississippi or Ohio at Cleveland Clinic, it would have a different sensitivity because there is a very high chance that you're looking at a granuloma there, rather than in Denver, where you have a very high chance that you're not looking at granulomas here. So a lot of benign solitary pulmonary nodules are seen depending on where you are. They could be granulomas, infections, or infectious granulomas, benign tumors like hamartomas or lipomas, or other pseudotumors and abscesses that can show up on the CT scan. And of the malignant nodules that we see, majority of them are going to adenocarcinomas. And then second more common would be squamous cell. Adenocarcinoma is now considered to be the most common malignancy seen in non-smokers. So it is common regardless of whether a person is a smoker or a non-smoker. Small cell carcinomas are uncommon, but almost always seen in only smokers. Non-smokers rarely ever have these tumors. We then do a PET scan. So for our patient, in this case, we would do a PET scan. And PET scans are extremely helpful in risk stratifying patients, as well as staging the patients with malignant nodules. So they serve both purposes. And should be done whenever there is a major question about whether we should proceed with invasive testing or biopsies or not. So sensitivity of PET scan is almost 72 to 95%. So we consider it almost 80 to 90%, which is pretty high. Specificity is about 83%, because even granulomas can be positive. Infectious nodules could be positive, PET positive. False negative results are usually seen in patients who have even a malignant nodule, but it's less than 8-9 millimeters. So they will not have enough rapid growth to be PET positive. And then rarely in well-differentiated adenocarcinomas, but more commonly in BAC, we used to call them bronchoalveolar carcinomas, but now we call them carcinoma in situ, or in radiology terms, we call them ground glass opacities, which are almost always adenocarcinomas. So they are slow-growing tumors, and PET negativity is very common in them, but that does not mean that they're not malignant. Carcinoids are often PET negative. And then granulomas, as I mentioned earlier, we see sarcoid all the time showing up as positive PET scan, and infectious nodules, infectious granulomas, TV granulomas, they're all PET positive. So PET by no means is a definitive test. It is a very good supportive test after the CT scan prior to proceeding to invasive testing. And then there are multiple ways of doing invasive testing or tissue sampling. You could do a bronchoscopy or transthoracic or surgical biopsy. And that's, again, a major decision that we have to take based on the location, the size, and the nature of the nodule. Because all three of them have their own pros and cons. For transthoracic needle biopsy, the sensitivity is very high. 90% specificity is extremely high because you see what you are hitting with your needle. So there are very little chance that you will miss it. The problem arises is that central nodules, which are away from the diaphragm, are very hard to biopsy, and the risk for having both non-diagnostic biopsy due to respiratory movements as well as complications such as pneumothorax increases. And the complication of pneumothorax increases exponentially as the lesions get smaller and further away from the pleura, and as the emphysema, severity of emphysema increases in these patients, which is really very common. Most of these patients have emphysema. So 15% pneumothorax rate is considered relatively high compared to other modalities such as bronchoscopy. And about half of these 15%, around 6%, will end up getting a chest tube and staying in hospital for several days. This was a large study which looked at the complications of CT-guided biopsies and all three major complications, or two major complications, hemorrhage and pneumothorax. Again, approximately 15% had pneumothorax and 1% had hemorrhage, and about 6.5% required chest tubes. Bronchoscopy, on the other hand, has come a long way. These are cumulative data from FCCP guidelines and meta-analyses, looking at 36 or 35 studies, 4,000 patients, and the yield was about 88%. And then another 34 studies, about 6,000 patients, yield is about 78%. The devil is in the details of this yield. If you look at the nodules which are under 2 centimeters in size, the yield is not as impressive as we all think. And if you look at the nodules more than 2 centimeters in size, the yield is very good, 63%. Keeping in mind it's the risk of pneumothorax and bleeding is extremely low in these patients with bronchoscopic approach, and the complications other than that bleeding and pneumothorax are rare. This is again, same point, smaller nodules are now in this study showing much higher success rate, 61%, and larger nodules, 82%. And the reason for that, I'll tell you in a second after we look at a couple of more studies, as you will start seeing here, we're using radial ultrasound, endobronchial ultrasound, which increases the yield very significantly. We're using electromagnetic navigation systems. So if you combine these two, which we mostly do, the success rates and safety of the procedure has improved a lot. Other studies looking at the similar data, and you will see more and more accuracy of bronchoscopic biopsy with ultrasound usage and navigation usage. And now we have robotic bronchoscopy, and that is expected to increase the yield even more. So the point is multiple ways of biopsying these nodules, and EBUS and navigation systems improve our yield and safety of the procedure. And one of the last things that we do in patients who have pulmonary nodule is the genetic and mutation analysis. So initially, there were issues about the amount of sample we can collect with different modalities, such as endobronchial ultrasound and needle biopsies. But over the last 4 or 5 years, it's been proven beyond any doubt that 99% of the EBUS samples, endobronchial ultrasound guided transbronchial needle aspiration of the lymph nodes, which is a minimally invasive, very safe procedure, ultrasound guided biopsies of the nodes here, shows that EGFR and KRAS and all other mutation analyses can be done without any problem. Whether the samples are done by 21 gauge needle or 22 gauge needle, whether the samples are frozen for a week or non-frozen. So very high rates. Transthoracic needle aspiration by CT guided or transbronchial biopsy, on the other hand, has less success because their samples are much smaller. Body fluids can be used, and then other smaller needles can be used. So the bottom line is, it is almost unthinkable now that we would do a biopsy of a mass in the lung or in the mediastinal lymph nodes and not do genetic analysis. This is the new norm of lung cancer diagnosis and staging. So here is the overall specimen insufficiency rate by procedures. Ultrasound is very low. 96% of the times we were able to collect samples which were not only diagnostic, but enough for genetic marker studies and driver mutation studies. TTNA, 5% failure rate, body fluids are even less. So again, no matter what we do, we collect these samples and they're extremely effective in collecting genetic material. And what is now the sort of a new thing that we are still exploring is, as you saw when I showed you that scale of high risk, medium risk, and low risk patients, that there is a big gray area between 10% or 15% to 60% of the probability, where the question of whether we should do biopsy or we should do resection is very complex because the risk is the stratification puts them into a moderate probability. And then if patient is high risk with emphysema or pulmonary hypertension or location of the nodule, then we're sort of faced with the dilemma of whether we should follow or continue biopsy. Now, even in NLST, which was the largest screening trial in the world of 53,000 patients, more than 90% of the biopsies done in those high-risk patients and surgeries done showed non-malignant nodules. So a large number of unnecessary procedures were done. No matter how sophisticated we get with our technology, this number has to go down with some other way. Otherwise, we will keep doing bronchoscopies and navigation biopsies on these patients and not finding tumor in more than 90% of the patients. So the genetic classifiers have been studied now extensively. Two of the initial major trials were AEGIS-1 and AEGIS-2, which looked at samples either collected from brushes from the bronchoscopy or brushes from the nose at the time of bronchoscopy. And they help risk stratify patients in that gray zone between 15 to 65%. And the combination of those classifiers, whether the lesions are potentially malignant or not, with the bronchoscopy brought us to a sensitivity of approximately 96% to 98%, which is extremely high. And now recently, another trial was published, Panoptic, which risk stratifies patients even better than AEGIS-1 and AEGIS-2. So we're at a point where we might be doing simple nasal brushes or bronchoscopic brushes of these patients to determine what is their true risk for having a malignant tumor. And after that, we present these patients at the tumor board with all the information, biopsy results, genetic marker studies, classifiers, and then all of us sit down every Monday morning from noon to 1 and discuss whether this patient needs to go further in terms of biopsy or testing or treatment or just a plain follow-up. We are very big center at University of Colorado for lung cancer research. Every Monday, at least half of our patients are plugged into one or the other research clinical trial, whether they have a stage 1 or a stage 4 lung cancer. We're very big on biomarker-driven personalized therapies. A majority of our patients now are on biotherapy, immune checkpoint inhibitor therapies. So in conclusion, millions of pulmonary nodules are discovered annually, and this scans, and we need to be smarter about their management. A multifaceted approach is needed to avoid unnecessary invasive sampling and surgeries. Established guidelines and risk calculators are extremely helpful in risk stratification. Genomic classifiers are helpful in intermediate risk nodule patients. And finally, multidisciplinary approaches in complex diagnostic cases in all patients or management is extremely helpful. Thank you very much, and I'll pass it on to Jamie for a much bigger national and global perspective. I'm gonna unshare my screen, Jamie.
And I will unmute and start to share my screen. Thank you for that overview and kind of local perspective on things, and bringing in the case perspective to talk about the implementation of lung cancer screening, I am going to go into the weeds a little bit with some of the logistics and from the community and individual perspective in terms of how we go about implementing lung cancer screening in as effective a manner as possible. And so I wanted to put up these transparency issues, potential disclosures, and before we move forward. So we have, as Dr. Musani's outlined, we have tremendous promise. We have a paradigm shift going in our efforts in lung cancer prevention and control. We have strong data from NLST and Nelson. We have policy and financial supports in terms of insurance coverage, but our next challenge is really getting this implemented effectively in a variety of settings, not just in academic medical centers, but in our community settings that may not have the luxuries of some of the supports that we do with terms of multidisciplinary teams, and yet this must be done in a quality way in those settings in order to achieve the full potential of lung cancer screening using low-dose CTs. So in many ways, we are amidst a really I would say, beautiful story of clinical and translational science, where we're working on that final step of translating our, hard-won data and lots of work, as referenced in some of the questions. You know, we've learned from those X-ray studies done in the 70s to some of the early LCAP studies in the 90s about the potential for low-dose CTs. Finally, with the NLST data, that was truly landmark and transformative in terms of our perspectives on the potential for implementing lung cancer screening, and yet substantial barriers persist. And really, I believe that implementation science is the path forward to understanding those barriers, as well as the facilitators that we can use to influence the successful implementation of low-dose CT scans and reach that full potential. In some ways, I see I equate low-dose CTs with this beautiful new Corvette. We have a tremendous, beautiful machine that is ready and raring to go. We have the data, which is our fuel to power this machine. And we have our programs that have been developed in all kinds of different ways. If you look at the ACR registry, you can see a blossoming of all the different programs across the country. And we have our primary care partners who serve as the ignition switch to get this machine rolling in order to have its utility. But we also have a very inexperienced driver at the helm, and that is the participant, the screening candidate, the screening participant who is inexperienced. And we don't have much experience with lung cancer screening either. All of it, or the vast majority of it, comes from a research setting, and we have that translational gap that we have to address. And so there are going to be challenges as we navigate this bumpy new road course. And boy, has it been bumpy. We have significant challenges that have been already identified in the literature, from poor uptake to limited shared decision-making implementation, to screening the wrong people, to have an imbalance of benefits and harms. So there are lots of challenges. Just to highlight the uptake, there's a couple of studies that have been reported showing that uptake prior to policy was very low, appropriately low. You could argue that it should have been even lower at this time based on our data. But after the launch of lung cancer screening with both policy supports and the data, you can see this dramatic increase, right? No, it really has landed like a thud in most situations in terms of the implementation and translating it. So why has that happened? Well, translation takes time, but that's not a satisfactory answer, of course. But to me, there's been this field of dreams fallacy that has occurred. If you build it, they will come. But that fails to understand the fundamental elements of who the community is we're trying to serve. And until we can raise community awareness through organizations and perfuse this information through our healthcare systems, to work with our primary care clinician colleagues to develop workflows that integrate lung cancer screening, and to identify those individuals who are eligible, we are going to continue to struggle with the policy uptake. Even those interventions that have been done to try to establish a cadre of individuals who would be entering these programs have been done incorrectly, in my opinion. We've used fear appeals to drive them, essentially sending the message of get screened or die of lung cancer. That is not an effective approach to engage a community of individuals who already experiences a high risk perception. In many ways, we need to modify that and lessen that risk perception so it's not so scary of a concept to engage us. And we've also used very stigmatizing appeals. This is a stigmatized community, largely driven by their tobacco use and our aggressive tobacco control activities that have tended to alienate them from our healthcare community, and there's generating a lack of trust and concern. And we just need to have some of our we can take some of what we've learned from our colleagues in mammography and colorectal cancer screening to help understand how to engage this community of individuals in order for them to see us as an asset in their health. Another thing that it has been very implemented variably across the country. But I want to tell you a story about largely focused on our work in Kentucky, where Kentucky has managed to leverage this opportunity more effectively than most other states. And perhaps the proudest graphic to my career to date is the one on the right-hand side up here, where you can see that this figure puts the low-dose CT rate among states across varied by the burden of lung cancer. And unfortunately, Kentucky is way out here in terms of the burden, but we're also way up here in terms of the actual implementation of lung cancer screening, showing that our partners who have a similar statewide burden of lung cancer in terms of Tennessee, Alabama, Mississippi, Arkansas, West Virginia, Oklahoma, Louisiana, are not leveraging the lung cancer screening environment and serving their communities effectively. But the efforts that we've taken in Kentucky have helped us achieve this outlier status. Now, we certainly prefer to be over here where Massachusetts, Vermont, and New Hampshire is, but unfortunately, the society and culture of Kentucky lends us to be here and to hopefully use low-dose CTs to move backwards in this mortality rate space. And in order to achieve that, our story includes a focus on the individual, integrating person-centered approaches into our lung cancer screening programs, as well as adopting a heavily infused community engagement approach to help expand awareness across the spectrum, from community to candidates and participants themselves, working with screening programs to implement quality, working with healthcare systems to diffuse information, and as well as educational systems and tracking strategies throughout systems, as well as working on a national level to monitor uptake as well as feedback into the systems. We've adopted a socio-ecological model of implementing lung cancer screening, and I'm going to talk to you about some projects that focus on our work with screening candidates at the LCS lung cancer screening program operations level, as well as some efforts in community engagement. And I want to emphasize the fact that we are at such an interesting and yet new, we're babies in terms of implementing, and we know far less than we need to do this as effectively as possible, is clear from the uptake data. You can see that. But at this time in history, we have to leverage these person-centered and community engaged approaches in order to achieve that full potential. And certainly there's possibility of backing off of some of these strategies as we achieve a social norm of lung cancer screening. It's just like in any other cancer screening for those individuals who are eligible. When I talk about a person-centered approach, it comes from understanding this community of individuals in a unique way, the ones we're trying to serve and are eligible for lung cancer screening. Hopefully not stereotyping this community, but understanding the vast majority come in from a stigmatized perspective. We always have not embraced this community based on their eligibility and their smoking history. We've not always embraced them in healthcare as effectively as we should. They also often share a fatalistic view, a nihilism toward the efficacy of lung cancer care. Now, we know as clinicians that it's transformed completely, and it's transformed and turned over almost on an annual basis in terms of what our evidence-based practices are. In the last 10 years has been so remarkable, but that information is not perfused throughout society. There's also a natural skepticism based on some of how we've interacted with this community in the past as well, that they bring to an innovation perspective. This is also a disengaged community, which also links to some of these other beliefs in terms of playing a rather passive role in their own health and well-being. And finally, they're dispersed. A lot of the burden of lung cancer risk is in our rural communities, requiring travel and other logistical supports in order to engage our lung cancer screening programs. And so one of the things that we've done is to try to engage them with information and develop tools to help them participate more actively in their lung cancer screening considerations. This is one project with my colleague at Moffitt Cancer Center, Dr. Margaret Byrne. We developed an informed decision-making tool to help people make choices. And I don't have time to get into the weeds of this, but we focus on delivering accurate knowledge, empowering them to talk with their clinicians about the screening option, and to clarify and to put their values and to put the context of lung cancer screening information into what their healthcare goals are in order to achieve these whether to make a decision as to whether to participate in screening. And here's just a screenshot of what the Lucas Choices decision aid looks like. We've done a preliminary feasibility and acceptability study showing that it is equivalent to the NCI website, but there are some unique advantages to the Lucas Choices strategy. It builds more engagement, people are more interested in it, but there were, on this preliminary study, there were no differences in terms of usability and feasibility of our study, and but it has guided toward us to make some choices about changes we want to implement in the second 2.0 version, and we've submitted an R01 with good feedback, and we're in the process of revising and resubmitting that grant to have an impact there. In terms of community, we really have to think of what our community understands about lung cancer screening, and it is quite modest. You know, what if you compare what percentage of individuals understand what a mammogram is in our society versus what percentage of our society understands what a low-dose CT is about, and that's kind of the community level engagement challenge that we're facing. In Kentucky, we developed what we called the Lung Cancer Screening Roadshow, where we visited 14 sites throughout Kentucky and partnered with clinicians and advocates and community members for a bi-directional sharing of cancer-related concerns and ideas and data with regard to lung cancer burden in their communities in order to start the dialogue between communities and hospital systems with regard to the lung cancer screening opportunity. From that, we learned that primary care clinicians needed a lot more information about lung cancer screening in order to achieve broader implementation. So we developed a typical grand round style continuing education program focusing on screening fundamentals and shared decision making, because it is a vital part of lung cancer screening, and then a process of working toward trying to achieve multidisciplinary collaboration in the lung cancer screening space. We were able to improve knowledge and improve confidence in people's clinicians working with the lung cancer screening community. But you'll notice that even this education wasn't enough, and we needed more to help them integrate it. And so we developed a grant called the Kentucky Leads Collaborative. It was funded by the Bristol Myers Squibb Foundation to reach more clinicians with provider education about lung cancer, and then also to on working with lung cancer screening programs to help them implement quality efforts. And none of this was particularly that innovative except for the fact that we combined academic detailing, grand rounds presentations, online delivery, and webinars in order to reach an astounding number of primary care clinicians and non-clinicians who were educated about lung cancer screening in order to truly perfuse this information about lung cancer screening and its potential throughout every possible healthcare entity in Kentucky. And it paid off in ways that link to the previous slide in terms of implementation. But one of the other challenges is working with lung cancer screening programs with differently equipped disciplines and differently equipped sites to help them implement it in rural settings. And so we integrated evidence-based practices to develop a quality implementation system, that we had resources that we brought to the table, as well as an evaluation or quality metrics that we brought in order to evaluate the outcomes on lung cancer screening and implementation. It was largely an audit and feedback system where we provided this quality metrics and we linked them with our resource portal, which included continuing education and lots of other assistance with documentation and materials to facilitate implementation. But the heart of it really was this QUILS index that focused on, that took the work of Peter Musani and others on implementing quality lung cancer screening, and we quantified it. We gave scores, and we diversified it a bit to include some of the community and person-centered focuses that would lead to successful implementation of lung cancer screening. And our idea here was we would go in, assess the quality, deliver that feedback, connect people with our resource portal, and then ultimately facilitate their implementation of quality lung cancer screening and hopefully see changes. We have implemented this at 10 different sites throughout Kentucky, and in order to achieve this benefit. And I don't have data to share with you on outcomes at this point, but I'll tell you in the next year or so, we're going to be rapidly analyzing and sharing the data to see how we've impacted quality implementation in Kentucky from the program level. But one of the other key challenges has not been just uptake of lung cancer screening, but how do we engage them? How do we keep them coming back? Because one of the fundamental underlying and underaddressed issues in lung cancer screening is adherence. As you see the data here from the NLST, there was 95% adherence to the lung cancer screening algorithm in the CT arm and 93% in the chest X-ray arm. But what are we seeing in the community? In Kentucky, we saw rates as low as 20% annual screening, and some folks weren't even following this statistic, not knowing that it's important at all. More recently, the VA reported some much better numbers, but still suboptimal in terms of translating NLST results into the community, and other more recent reviews and clinical reports. But the most recent data that was just reported by Gerard Silvestri shows that nationally the rate is 20%. And I'll submit to you that there's no way to achieve the individual or population health benefits of lung cancer screening that were demonstrated in NLST with an adherence rate of 20% to annual screening. So we developed the engaged approach to lung cancer screening to try to help with this, and it's under evaluation with colleagues in longevity to treat every candidate and participant contact or communication as a precious opportunity to build engagement and adherence in the program. And we have to be thinking about adherence, not just to cattle call them into the program, but building supports into the system that fundamentally address them as individuals and help them build engagement. That every individual in the lung cancer screening program messages engagement in their interactions with participants, and we have some mnemonics to help with that. But we also showed that data that sort of establishing a single point of contact for program questions or issues, and it's about the relationship at this stage when we're developing something novel. The participants need to feel a connection, a simple connection, and to build the policies and procedures to demonstrate support and really place the participants at the center of the process, and to also engage referral sources in this process of problem solving and developing the optimal strategies to engage this community. So a quick summary: we have tremendous promise to absolutely transform the lung cancer landscape and help our thoracic surgeons do a lot more lung transplants and a lot less cardiothoracic surgery in terms of removing lung nodules and reduce the burden of lung cancer totally through the NLST. But the implementation has been a huge challenge, and we have a relatively small window of time to create and develop the strategies to optimize this and to address these challenges before our communities develop some really bad habits and totally fail on terms of the implementation. And I believe that person-centered approaches with substantial community engagement, thinking across the sociological spectrum and using multi-level interventions are the path forward, and that implementation science is truly the platform in which to achieve these outcomes that we hope to achieve. And I I will stop there, but not before spending just a second to thank all of the clinicians on the line today for all the work that you've been doing, putting yourself at risk and your families at risk in terms of managing the COVID crisis. As a non-practicing former clinician, it is remarkable and truly appreciated by the community, all the work that you've exerted in terms of managing this crisis. So thank you. I'll turn it back to Dr. Schwartz.
Jamie and Ali, thank you very much. That was a great presentation. We have a few minutes for questions, and we have a few questions. So tell us a little bit more about translating the findings of the NLST to the community. Who pays for the CT scans, and is a shared decision-making necessary as part of the steps to obtaining these CT scans?
Absolutely. Yes, shared decision is required by CMS, otherwise Medicare would not pay.
Ali, could you speak up just a little bit?
Sorry. So yes, the shared decision-making.
You're not quite coming through, Ali. Jamie, why don't you take that on?
Yeah, I'll take it. Sorry, Dr. Musani. So yes, shared decision-making is required under the Medicare guidelines for those individuals who are covered by Medicare, and it's been adopted by some other private payers as well. There's actually a separate billing code that's required. Now, I will say it's required but not monitored, and yet they've not enforced the policy that you have to have documentation, but CMS could go back and review those at any time they please to show you're out of compliance, which would of course be a very bad thing. But I think we want to do shared decision making not necessarily for its benefits of checking the box and making sure we get paid, but it is the pathway to engage these individuals who are less than engaged, that helping them buy into this decision that they're making so they keep coming back. One-off screening where we get them in the door one time and they never come back to us, whether it's because they've got a clear scan and they can come back and we can find something early next time, or even there's a low adherence rate for those people where we do find there's problems getting folks with lung rads 3s and 4s back into our clinics, particularly in rural areas. And that's a real catastrophe in my mind, to have something where we know there's something very suspicious in someone's lungs and we can't get them to come back in because we didn't do the patient engagement initially to help them understand the complexity. The other thing that was in the chat question was about tools to help facilitate shared decision making. There are a host of decision support tools. The one that I mentioned is not relevant because that's an informed tool that's designed for consultation work to help the clinicians or help patients prepare for a shared decision-making consult. But the AHRQ has a comprehensive list of tools that are available for clinicians. It's a little bit more robust, but led by Dan Matlock and Russ Glasgow and the team here, we're developing a new one that is briefer, more efficient, and can help primary care and other clinicians achieve a shared decision-making consult that's more efficient and fits better within the workflow. But that's going to be a little bit of time before we finish that up. But you can get online and look at some advocacy organizations who have also posted shared decision-making tools to help structure that conversation, whether you're in primary care or you're at the shared or at the lung cancer screening program level.
Thank you. I was wondering if either of you could comment on minority access to lung cancer screening and whether there's a differential uptake and involvement in lung cancer screening and in communities from different ancestries.
Jamie, I'll let you take it.
Okay, I got that one. So yes, we are very concerned. I mean, we're at the initial stages of launching lung cancer screening. And so we have a real opportunity to understand how implementation will vary in different communities. And there's already sparks of concern about this, particularly in the African-American community. The U.S. Preventive Services Task Force has recently re-examined the eligibility criteria. And it's not policy yet. We're all waiting on pins and needles to see what the final final decision is. But one of the motivations to expand the eligibility criteria to 20 pack years and to a minimum of 20 pack years and age of 50 is because African-American individuals tend to have higher lung cancer rates that fit into that more modest risk category. Those of us who have just a little bit of epidemiology training are a bit concerned about the expansion of that because it's going to alter our false detection and false positive rates and perhaps lower the yield among a lower risk community, which is going to cause a number of different challenges. And so once again, it's an implementation question that's very challenging. We also have other communities that we need to be concerned about in terms of uptake of lung cancer screening. And that is individuals who have communities that have a higher rate of tobacco use. I'm thinking of documented tobacco use rates in the LGBTQ community, in the community of individuals with mental illness. And yet we need to target and tailor our communications and our engagement with those communities at this early phase of implementation, not wait until 10 or 15 years down the road when we can document, boy, there's 20% uptake difference between this community and that community. We should have done something about it 20 years ago. We know those disparities are likely to emerge. Some of them have emerged already. They're likely to get bigger. Let's do something about that now so we don't have to tell that story 20 years from now and try to address the problem. And so that's one of the other things that we're working on with moving our lab here to Colorado to address some of the communities that are uniquely need to be served here.
Yep. That's great, and a really constructive, proactive approach to a problem that likely exists. So thank you. Unfortunately, we've run out of time. We have many more questions. We'll be serving these questions up to you and post medical grand rounds, and you can answer them for the larger audience. Again, I want to thank both of you for this really informative medical grand rounds. Very, very helpful. I want to also wish everyone a healthy, happy new year and good holidays. Get some rest and hopefully come back next year recharged. Thanks a lot. Bye-bye.
Thank you.